This presentation is going to focus specifically on some of the demographic trends and their implications for the alcohol and drug sector in relation to the ageing of the Australian population. So, we know that there's a growing interest and concern about the use of alcohol and other drugs amongst older people. And there's going to be more people using more psychoactive drugs as they age than we've ever experienced previously. And so what I'm going to do here is talk you through some of the major demographic trends that we're aware of that have been occurring, and some of the factors that might be contributing to potential problems and what some of the service system responses are required in relation to that. So I'm going to look at trends and patterns, causal and contributory factors, current and projected impacts on services, and then potentially some of the mechanisms for addressing emergent needs and enhancing intersectoral collaboration. And some of these issues, to some extent, Gerard has touched on in his previous presentation as well, so that was really helpful in that regard. So we're quite aware that there's been an important shift in the demographic profile of Australia. People no longer talk about age pyramids, the pyramid structure where you had most of the population concentrated in early age groups and then thinning out as you got into sort of 20s and 30s and then really tapering towards a thin peak from the 70s on. That age pyramid doesn't hold any longer. The shape of the pyramid is quite different, and if you see a series of graphs and figures that are overlaid, you can see how the shape of it's changed with a great bubble in the middle, so it looks like an apple, and then the apple is sort of starting to explode at the top as well. But there's a huge political agenda that's attached to this growing of the population, and so you would have seen some of the reports that have come out from the government recently, and I'll talk you through some of those about what the implications are for both the economy and how we're going to maintain our economic base and employment prospects and so forth. So in trying to pull a lot of these issues together, and CEDA has done a number of things. There's a small little resource kit that we've produced with some information sheets in here covering off some of the key factors of interest. And we're also just finalising a guideline for clinicians that we're producing with the Peninsula Health Group from Victoria, looking at what are some of the treatment implications for managing alcohol and drug concerns with older people. So things that are going to be helpful to us in the not too distant future. In terms of different perspectives about ageing, there's some interesting kind of politics, small p politics around this one. So whilst there's a growing interest in healthy ageing and well-being, there's a really strong push. So some of the material that we had started to put together, we'd started to use some of the terminology that you will hear in terms of silver tsunamis and this sort of thing. And we were quite chastised about doing such a thing because it's quite has negative connotations. And so a really strong push for those who work in the aged care sector to not see ageing as a disease state or an inevitable degenerative process at all. And the whole notion of restorative health has got real impetus at the moment. So this notion, if you might be in your 70s and 80s and develop some kind of severe health condition, that it's part of the inevitable decline. People are arguing that's actually not the case at all, and the notion of restorative health has taken on huge ground at the moment. So really interesting shift. So a big push away from pathologising the ageing process and limiting the extent to which we problematise it. So I think that's helpful for us. In the alcohol and drug sector, we tend to see through a lens of problems most of the time. There's also a bit of a tendency to patronise and hold fairly paternalistic attitudes about older people and the ageing process, and to stigmatise drug use in general, but particularly when it's among certain groups, including older people. So there's a whole raft of interesting issues that swirl around it. In our local newspaper in South Australia last weekend, in the Courier Mail, there was a whole spread about this issue about sort of new images of ageing, which I thought was sort of quite relevant to this. And we see it in some of these kind of high-profile, kind of iconic figures, and they're often people in film and theatre, literary figures, and the artistic world. But the notion that you would have sort of the Mick Jaggers of the world from some decades ago still performing as rock performers now, into these people sometimes into their 70s and 80s, was something that we didn't really conceive of as being possible only a short period of time ago. So the whole concept of how we age and what older age looks like is really changing very much before our eyes. And now there's a multitude of incredibly kind of, dynamic, positive figures who are substantially older than might have been the case for such role models previously. So the notion of ageing is changing quite a lot. How we define older people is also a little bit of a movable feast to some extent. So the definition, when you wake up now at the same time that you used to go to bed on a Saturday night, that's the definition of being old. But for many purposes, we would think certainly over 55 for many of the health studies that we engage in, and sometimes it might be 60 or 65, and then we start to categorise and demarcate. So grouping such as the young old, so that would be the 60 to 65s, maybe 75, old, 75, 85, and then very old, 85 and plus. For Aboriginal and Torres Strait Islander peoples, it's been suggested to us by our Indigenous colleagues that that cut point might be as low as 40 because degenerative processes start to kick in at a much earlier stage. Life expectancy is also considerably truncated amongst the Indigenous population. We're seeing this unprecedented shift in older populations. I'll see if this works. So this grouping here is our 65 years and plus group. And so the shift from kind of pretty much where we are there at the moment around 2015, 2020, we're going to see a larger proportion of the population aged over 65 than we've ever seen previously. I'll show you another graph that captures that much more clearly, but I'll come back to it in a moment. But there's huge political interests and agendas sitting behind this, so that many of you would have seen the intergenerational report on Australia that came out just a couple of months ago. And the emphasis here was that the age pyramid or the profile of the Australian population is changing such that it's going to be very difficult for us to think about how the shrinking population of younger people is going to support the increasingly larger group of older people. So to bring that home, that the estimate is that the proportion of older people aged 65 years and over will increase from around 14% now to about 18 to 20% of the population in 2026. But in 10 years, that will mean 1 in 5 Australians will be over 65. Which is a really large proportion of the population. So it's not just absolute numbers, it's the proportion of people who are over 65. And so the other data that was produced by the Joe Hockey report was this, that the relative, the proportion of people over 65 relative to people aged 15 to 64, so the 15 to 64 is to say your working population, in 74-75, there was about 7 people aged 15 to 64 to support every person over 65. At the moment, that's about 4.5 people under 64 to every person over 65. And in the next decade or two, that will be 2.7 people between 15 and 64 relative to every person over 65. So it's that ratio there that has got people concerned. That the concern is that that's a very small population base to be supporting a larger old population, many of whom will have been retired, although if the current government has their ways, we may not be retiring at all. So, and the other big shift that's going to occur is the proportion of people who are over 100. And so that by around 2050, we expect there's going to be something like 40,000 people over 100 in Australia. And the view is also that the first person who's going to live to 150 has already been born in Australia. So into the next few years and decades in front of us, the ageing profile of Australia is going to change really quite dramatically in a way where we've never seen previously. And so some of the things that we're seeing just at the moment would suggest that this is just the tip of the iceberg. And I understand that this is actually the iceberg that sank the Titanic. It's from an archival photo. I can't verify that. So let's then turn to think about, well, what are then the implications for that ageing process and the changing demographic profile of the Australian population in relation to alcohol and drugs? And does it matter? Is there a difference? And this is where the story, I think, gets incredibly interesting. So what I'll do here is I'll look at sort of the more common things, more common drugs we'd be using, so alcohol. Tobacco is interesting, but I won't be touching on it. Some of the illicits, particularly cannabis, and so the data on cannabis is quite interesting. And we're seeing some shifts around stimulants, the opioids, and particularly the prescribed opioids, and some of the other prescribed medications, such as the benzos and over-the-counter medications, which might also be containing opioids. So there's really important trends that are occurring there. I'll look also briefly at the OST population, who are another ageing cohort and brings with it all sorts of interesting challenges for us. But in looking at the epidemiological profile of drug consumption amongst this age group, we need to think about what are the implications for both our services, our community, and our retirement facilities and villages, many of whom are now approaching us for advice. So basic questions. Well, why would older people be using alcohol and drugs? For pretty much the same reason as the rest of us. So the 4 Ps, the 3 Ps, or the 3 Fs, we use things because they're incredibly pleasurable, which is why part of the reason we're having so much problem with methamphetamine at the moment, hugely euphoric effect, and then potentially lots of problems afterwards. To deal with pain, and it might be emotional pain, it might be physical pain, and it's purposeful. It has functions. Most drug use has a function of different sorts. So people use the same drugs for the same reason as the rest of us. So the issue for us is this ageing population, ageing at a faster rate than ever before. The advances in healthcare are such that we've got increased longevity. That will increase into the future as well. Dramatic increase in the number of older individuals with alcohol and drug problems, and that's what our data is now showing us. Amongst older people, there's a decreased incentive to change until problems become severe. So many problems and potential sleeper problems in relation to alcohol and drugs don't become apparent. They're not looked for. They're not something on the radar of our primary care services. They don't get subjected to screening. So it really is a sleeper problem. And often when the problems are detected, they're more severe than they might have been had they been detected earlier. We'd also argue that amongst the 60-plus age groups, the baby boomer plus group, grew up at a time when there was a very strong view that there was a quick fix for most things. A pill and a medicine was going to cure most of the ills that we were concerned with. So a very easy reliance on medication and self-medication for all sorts of things. The next statement is a little bit, if not contentious, it just needs to be tempered a little, that for many older people, they have greater disposable income. This is clearly not the case for everyone, but that will facilitate use of alcohol and drugs as well as the corresponding problems that might go with it. So our baby boomers, the baby boomers are people born between 1946 and 64. That's a group that have used alcohol and drugs at a higher rate than previously. So the baby boomer generation were the people that grew up in the psychedelic era of the 70s, the 60s and 70s, and for whom alternative lifestyles of different sorts were actually much more radical than their equivalent age groups today. They often hold much more liberal attitudes towards alcohol and prescription medicines and illicits than slightly younger generations, ironically. And also, this is not a problem unique to us or a situation unique to us in Europe and the United States. The number of older people with substance use problems is predicted to double over the next couple of decades. And the other thing that's been really interesting to that last comment there, and in relation to people who had HIV/AIDS and people who are on our OST programs, many people have made this comment. I did not expect to be here. I actually have spent all my life resources I fully expected not to survive, but have. So there's a couple of quite important, unique sub-cohorts. So age-related risk factors for alcohol and drug problems, they include a number of things. So some of the lifestyle and situational factors such as retirement, loss of mobility and independence, medical illness, grief, social isolation, changing role, identity and confusion, and vulnerability to exploitation are some. But then more at a physiological level, you have a reduced capacity to metabolise most forms of alcohol and drugs. With the same intake, there's likely to be greater levels of harm. More complex alcohol and drug-related problems because of interactions with other pre-existing physical conditions. Multiple morbidities are likely to be more common. Multiple medications are likely to be used, and therefore with potential multiple interactions. And complex interactions between both alcohol and drug use, age-related cognitive impairment that might be occurring anyway, and then mental health conditions that might be occurring independently, such as depression. Greater risk of things like falls and other injuries, separate to any alcohol and drug use that again might be compounded by that. And then problems in terms of that the literature is just starting to show now about long-term exposure to opioids. Until relatively recently we had the view that prescribed opioid use was relatively benign except for maybe severe cases of constipation. We're now finding that that's actually not the case, and it's a risk for fractures and a range of endocrine conditions and a number of other things. We're also particularly concerned about older people from culturally and linguistically diverse backgrounds. We also know that many people from non-English speaking backgrounds, as they age, will sometimes revert to their original first language. Sometimes when people have experienced strokes, they need to be rehabilitated in their original language, not English. For Indigenous Australians, this is a huge issue. And then the old injecting drug group that I'd mentioned. So we didn't develop this full typology, we expanded it. Half of this typology existed, but we would argue that you could probably think of older alcohol and drug users in a number of different categories, one being the maintainers. So these are people who've maintained their previous and unproblematic use of alcohol and drugs, mainly alcohol, into older years, but age-related changes, and so that might be metabolic changes, you simply cannot as efficiently metabolize alcohol as efficiently as you get older, comorbidities or other medicines, they've resulted in harms in later life. But they're people that haven't simply changed their behaviours all that much. There's a second group we've called the survivors, that these are the early onset users who have a long history of substance use problems which persist into older age and who often have a range of other comorbidities. And then there's the reactors, who I think are a particularly interesting group. So this is late onset use, and problems begin maybe 50s or 60s or later, and may be associated with stressful events, so perhaps bereavement, job loss, retirement, marital breakdown or social isolation. The treatment responses for each of these groups, you can see, will be quite different, and the profiles of them are also quite different. We're also suggesting that in contrast to the greater demand for our treatment services at the moment being a kind of 2-to-1 ratio of males to females, with older age groups we're expecting to see a much heavier increase in demand, both risk and harms amongst women. And this is going to be the result of a number of factors. So women live longer. Many more of them will live alone, and living alone is a risk factor for a number of potential adverse outcomes. They often will not have the same degree of financial independence and security, making them vulnerable to a number of potential problem areas. More susceptible to the negative effects of alcohol and drug use in general, because we have proportionally more body fat and less body water to metabolise alcohol, for instance, just on that one alone. Higher levels of experience of anxiety and sleep disorders that are more likely to be medicated and to have prescribed for them anxiolytics and hypnotic medicines, which then may lead to a range of other problems. Certainly more likely to experience chronic pain. This is what the data tells us. And AOD problems, again, may go undetected, and resulting in lost intervention opportunities and an accumulation of harm over time. So for women, older women, we think that there's a particular need on the horizon to look very closely to that. And I love this cartoon sent to me by a girlfriend that says, two older ladies speaking to each other, "To stay young," the doctor said, "exercise and eat the right food." Her friend says, "What? I thought he said accessorise and buy nice shoes." You see why she sent it to me. So in contrast to much of our preoccupation over the last couple of decades, where we've really been focused on the alcohol and drug concerns of very young people in their teens and their 20s, occasionally into their 30s, what we're seeing on the horizon here is a substantial shift towards problems with quite a different age cohort. Now, if I turn to the data to talk you through why we think this is going to be a problem, I think some of it is remarkably interesting. What you have here is the National Drug Strategy Household Survey data for alcohol and drinking trends for both lifetime and single occasion risk since 2001. As you know, it gets conducted every 3 years. So 2001, 4, 7, 10 and then 13. And what you see for the difference between 2010 and 13 here, that dip is a statistically significant decrease in the overall level of risky drinking in the Australian population. Now you can see it's pretty much a flat pancake, technical term, for the 10 years prior to that. That's a really interesting and unusual shift for us in the Australian population. And we think, what is happening here? This is exactly what we want to happen. We're not quite sure what's driven it. So there's a statistically significant decrease in the proportion of risky drinkers in the Australian population. And if you break it down by age, each of these shaded bars are the household survey data over those same years that I was showing you. And the dark orangey bar here is the most recent, 2013. These age groups here, the 18 to 24 and the 25 to 29, there has been a statistically significant decrease in risky drinking amongst young people. So see that dark orange bar here? And then previously, just between 2010 and 2013. And we think this is fantastic news. We're really thrilled to bits about this. It's exactly what we've been wanting to achieve for a long time. So overall, population level of risky drinking has gone down, and it's gone down with these potentially high-risk groups here. At the same time, if you cast your eye over here to the 50 to 59-year-olds and the 60 to 69-year-olds, what we see over here is a statistic. It's a little bit hard to see it in this graph, but I'll show you in another one. There is a statistically significant increase in risky drinking amongst this age group. We've never seen this before. First of all, we hadn't seen this, so we've got a really big demographic shift downwards here, statistically significantly so. But this shift here, so now we've got a trend where older people are engaging in risky drinking more than younger people. Not necessarily more than younger people, but in the opposite direction to younger people. So when you look at it a little bit more closely, that difference is occurring essentially in the baby boomer group. This is the 60 to 69-year-old group, and that shift between 2010, the blue bar, and 2013, the red bar, that's the significant shift that we're seeing here. Not seeing it in the 70-pluses, if anything, it's gone down a little bit. But overall, it's trending upwards. Thinking, how interesting. So, and that's short-term risky drinking, so that's more than 4 drinks in a session. Same effect, also statistically significant if you look at lifetime risk, which is more than 2 drinks in a session. So on both of those measures, you see exactly the same trend occurring. So the 60-year-olds here, significant increase in both short-term and now long-term risky drinking, a pattern we've not seen before. And I'll skip that, it's just too much detail. They're also the group, older people are also the group that drink most frequently. So the people who drink every day, that's the little orange square here. If you have a look at the 70-year-olds, they're the group most likely to consume alcohol every day, and the group second most likely to are the 60 to 69-year-olds. And you think, well, is that necessarily problematic? And the answer to that is it depends. Probably not, but possibly so, depending on the circumstances. So whilst overall we've seen a decrease in daily drinking over those years of the household survey, we're still seeing that it's the 60s and 70-year-olds who are drinking most on a daily basis. Anything you do on a daily basis is a real candidate for problems, and it becomes difficult to change those kind of patterns that occur for you. So they're a bit of a red flag, particularly when this is a group with all sorts of other potential vulnerabilities. So, in summary, this data looks like this. So single occasion drinking, risky drinking has increased by 31%. Amongst the 60-year-olds from 12 to 16%. Lifetime risk has increased, risky drinking has increased by 20% for that group. These are not trivial figures by any means. Is this showing up in our treatment data? The answer is yes. And so we looked then at the national minimum data set, so that all the data that's collected from the Alcohol and Drug Specialist Services, and it's a little bit easier to show it in this graph here. This is the number of people over 60 years of age presenting for treatment between 2002-3 and 2012-13, and it goes from just under 2,000 to just under 4,000 up here, so almost a doubling of people presenting to our services. So what we're seeing in the epi data is being borne out in our treatment services data as well. So increasing presentations, and we expect to see more of that. I'll skip over the hospital and the disease ones for the moment. Now let's just turn to illicit drugs and see what's happening there, because it's also good. In the sense of, sorry, it's interesting. It's what I meant, very interesting. So, you don't see much change in overall prevalence of illicit drug use in younger age groups in the last couple of years. It's quite flat, even with looking at methamphetamine. The 2013 data is quite flat, some small variations amongst current users. But we're seeing increases amongst the 40-year-olds and the 50-year-olds for illicit drug use here. So again, overall, over time, illicit drug use has gone down amongst 20-year-olds and 30-year-olds and is trending upwards, again, amongst the 50 to 59-year-olds. Now, this is cannabis, and then when we analyse this data, this is a statistically significant increase in cannabis use between 2010 and 2013 for the 50-year-olds. So again, like alcohol, trending down for younger groups and significant shift upwards. The proportion of the populations are relatively small, but because of the potential for elevated problems as you get older, it's increasingly concerning. And because of that ageing trend that we were looking at in the population overall, this figure is likely to start growing quite substantially into the future. Again, things that we haven't really seen previously. Principal drug of concern for cannabis amongst the over 60s. So we've seen a steady increase in presentations to treatment from 2013 around 28, not very many, and up to now a couple of hundred. So numbers are still very low. That's the way the trend is moving. Ignore that little dip there, it means nothing, there was no data collected as a baseline. But the principal drug of concern is really shifting up for older people in relation to cannabis. And cannabis is not a drug that people go into our services for a huge amount of treatment for to start with, relative to alcohol and heroin and meth, but it's still an important issue. If I turn to pharmaceutical drug misuse, we know, three. I have to pick out the best bits for you in that case, the best juicy bits. Okay, big increase in prescribed use of opioids in Australia as in the United States and in Canada. Canada's worse. Overall, it looks like this. Big shift, mostly things like oxycodone. Get the picture? So, but if you break it down by age, and this is the figure for oxycodone over years, it's most heavily used and prescribed by that red bar there, 80-year-olds, 70-year-olds, 60-year-olds. So huge levels of prescribed use of opioids amongst older age groups for a variety of different reasons. Just skip over all of this. Household survey data says misuse is also substantially greater. It's high with all groups, and trending up with all groups, but also quite high with the 60s and 70-year-olds. Hospital separations for poisonings for heroin and opioids. So we're seeing these presentations as part of adverse events. The blue bar here are the 60-year-olds. So high presentation, so lots of adverse, if you're presenting for an overdose for an opioid, huge adverse events for that, and increase in the proportion of hospital separations for heroin and opioids. Just ignore all that. And these are deaths. So I'm not breaking down by age, but when you have this exponential increase in your level of prescribed opioid use, there tends to be this concurrent running of a series of adverse events. This is deaths from oxycodone in Australia. So, and fentanyl is the other major drug of concern. The dotted line there are the 80-year-olds. Massive increase in the level of prescribing for older age groups. American data suggests that prescribed opioids may become a gateway for heroin use. So there's data to support that, and we're concerned about that. And we're seeing increasing treatment demand amongst this age group as well for opioids. And I'll just skip over that. The other ones is the ageing of the OST cohort, and so the proportion of people who are under OST now is higher than it's ever been previously and trending upwards, so that ageing of that cohort will continue as well. So what's needed to start to address this really strong both population trend, but also it's a behavioural trend that accompanies it. So better assessment. So we've looked at the assessment tools that are available to screen for older people for alcohol, because mostly people are screened out if you're over 65. They're not in our studies. So we need better assessment tools. We need identification of what safer levels of use looks like, given all the other co-occurring and contraindicated lifestyle and physiological changes. We need provision of support and care in collaboration with aged care and community services. They're coming to us seeking really strong and clear advice. We know people are using cannabis in our aged care facilities. What should we do? Should we be providing alcohol in our retirement villages? These kind of basic questions. And then clearer advice to older people and those who live and interact with them to prevent problems from developing in the first place. We're going to see the full constellation of problems that we would normally see from intoxication, from dependence and from regular use, and it will manifest in not dissimilar ways. We will see people moving up and back along that continuum of problems that occur around alcohol and drugs. So somebody who may have had no problems at some stage developing quite substantial problems later in life. And we also know that for older people, and Gerard tapped into this too a little, there's all sorts of barriers to treatment. So some of it's about shame and embarrassment. Physical access to services may not be appropriate, attributing alcohol and drug-related symptoms to ageing and therefore dismissing it and not recognising it as related to alcohol and drugs. Unsuitable services that have really been designed for much, much younger cohorts. Sometimes collusion by clients' families, or sometimes just not knowing where we might possibly go to turn to for help. And amongst ourselves, amongst health professionals, the barriers to treatment include a lack of awareness and an inability to identify signs and symptoms associated with it, lack of confidence and skills to work in this area, a reluctance to ask embarrassing questions of older people, a belief that older people are too old to change, or a belief, the opposite, that it's wrong to deprive older people of the last pleasures in their lives. So lots of little curly challenges there for us with that one. But we also know, as the literature tells us, even small changes can make quite significant differences in people's lives. So to think in terms of this is not so overwhelming. We need to think in small incremental changes, and that nudging can make a difference and help achieve, long, healthy lives and lifestyles for many of the people that we're going to be working with into the future. And we're developing a MOOC, an open online program, and dealing with alcohol and drugs in older people. Thanks for your time.